everyone. Good afternoon. Welcome to our next session with our lovely panelists, Representative Liz Miranda, Dr. Viveka Prakash-Zawiswa, Dr. Jallicia Jolly, who will all be discussing the recent news about Black maternal health policy here in the great Commonwealth of Massachusetts. I'm going to give everyone's bio and then I'll turn it over to them to introduce themselves individually and then we can start. First, I'll talk about Dr. Prakash Zawiswa. On this panel discussion focused on the state of Black maternal health in Massachusetts, we have Dr. Viveka Prakash Zawiswa, a physician leader with a passion for exploring how policy and systems impact healthcare delivery and outcomes. Dr. Prakash Zawiswa is an assistant professor of OBGYN and family medicine and community health at the University of Massachusetts Chan Medical School. In addition to serving as a medical director at Mass Health on the Payment and Care Delivery Innovation Team, where she develops new and innovative policy solutions to the challenges faced by the Medicaid population, Dr. Prakash Zawiswa is the president of the National Perinatal Association. We're excited to welcome Dr. Prakash Zawiswa to our discussion of Black maternal health policy in Massachusetts. Our next speaker is Dr. Jallicia Jolly. She's a panelist here. She's a professor, an equity practitioner, and an outstanding organizer. Dr. Jallicia Jolly is a visiting assistant professor in American Studies and Black Studies at Amherst College and co-chair of the Massachusetts COVID-19 Maternal Equity Coalition, of which I am a member, an interdisciplinary body that brings together clinicians, researchers, community organizations, advocates, legislators, and stakeholders to implement evidence based interventions to improve birth outcomes by addressing structural racism and medical violence in the care that Black people receive. Dr. Jolly also conducts research and teaches on Black women's health, grassroots activism, reproductive justice, and HIV/AIDS in the United States and the Caribbean. Our final panelist is Representative Liz Miranda. Rep. Miranda is a Massachusetts State Representative for the 5th Suffolk District. She works to reduce inequities and lead efforts to pass the Police Reform Omnibus Bill of 2020-21 and has previously passed legislation focused on improving maternal health outcomes for birthing people. She's a community organizer, a former youth worker, an entrepreneur, an advocate for health equity and economic opportunity. We are so excited, thrilled, and honored to welcome Rep. Miranda to our discussion of Black maternal health policy. Dr. Prakash Zawiswa, you have the floor. Thank you.
Thank you so much, Dr. Muta Onokaga, and thank you for including me on this amazing panel with these other speakers who have done so much for reproductive justice in the Commonwealth. I do have some slides that I'd love to share with all of you, and then looking forward to hearing from the other speakers and then having a discussion as well. So if we could go ahead and put up the slides, please. Thank you. So what I'd like to talk about today very briefly, this is a topic that could easily take up an entire conference and more, but I was hoping to just give an overview of the way we think about policies. I'm just going to share with you one framework of how policy is made and implemented and then refined. If you could, next slide, please. And go ahead and click, please. Thank you. So this is what's called the linear model of policymaking. There's many different models out there. This is just one of them. And again, this is a framework. This is not necessarily something that we strictly follow, or it's just a way to think about approaching a problem and then developing a policy to address it. So the basic steps are identifying the problem, formulating the policy, implementing the policy, and then evaluating it. And you'll see that I added my own step later, which is refining that policy, which I think is arguably one of the most important things to do. Next slide, please. So I'm going to talk you through this process, and I'm just going to use the example of Black maternal mortality as the problem that we're trying to solve with policy. So identifying the problem. Black people have 3 to 4 times the maternal mortality rate compared to their white counterparts, even with adjusting for income and education. This is the problem we're trying to solve with policy. So first we start with what are the root causes of this problem? These are obviously all of the amazing speakers all morning have talked about what I have on this page and so much more. So this is not at all an exhaustive list, but these are just some of the things that are top of mind when we talk about this problem: systemic and institutional racism and casteism, provider implicit and explicit bias, economic inequality that results in higher rates of public insurance and associated stigma and limitations in access. Again, not an exhaustive list by any means, but just an example of how we would start working through this problem. Next slide. So, policy formulation. What are some of the solutions that could exist for this problem, and more importantly, for the root causes, right? We don't want to just do a Band-Aid for the problem. We actually want to address what's causing the problem in the first place. Many of these things, again, all of the speakers have addressed, which I was very excited to hear. It's always wonderful when we're all kind of talking the same language and the similar solutions are emerging from these conversations. Access to doulas who are culturally and linguistically concordant, expanding postpartum coverage to 12 months, incentivizing preconception planning and counseling for high-risk conditions, which includes social factors, having quality metrics that are based on patient and consumer experience, quality metrics that are based on accurate reporting of race and ethnicity, and rates of maternal morbidity and mortality. As we know, that's a huge lack right now. Require or incentivize provider training in anti-racism and an implicit and explicit bias, and require patient and consumer advisory boards to have broad representation. These are, again, not an exhaustive list, but I was happy to see that many of these ideas have been echoed by others. Next slide, please. And then in terms of the implementation, so say we decide we're going to do some or all of these policies, how do we actually implement them so that they work? So in order to do that, we really need to understand that full landscape. So that means what does care delivery actually look like from before someone even gets pregnant to when they're pregnant, when they've delivered, and way beyond that as well. We want these policies to not, again, just be a Band-Aid. We want them to really address the problem. We want to gain insight and input, not only from the people providing the care, but from the actual patients and the people consuming the care delivery, because we may not know as policymakers what some of those blind spots are. We only see what we see, but there's so much that we aren't even aware of. So we really want to be sure we're hearing from as many voices as possible. We also want to anticipate any potential conflicts with policies that currently exist. We don't want to create a landscape where we have one policy trying to do one thing, but it's bumping up against something else. So everything should be in synergy. And then sometimes we consider a stepwise or phased implementation if that's appropriate. So sometimes we'll pilot something with a small group to test it out before we expand it to a full population. Next slide, please. And then this is a very important step. We actually want to then go back and evaluate what is the impact of the policy? What are the consequences and the results now that it's been implemented? Just some of the things we would want to know. What are the health outcomes? Have we actually moved the needle on maternal morbidity and mortality? That can be, as you know, a longer view of the horizon, but are there shorter term things we could measure in the interim, like utilization of certain services, hospitalization rates, things like that are more real time, but then also getting that longer view of impact on morbidity and mortality. Some of that is in quality metrics. And again, the patient and consumer experience, that's so important. We want to be sure that the people who are actually creating this policy for are experiencing it in a way that's positive. And then we also want to keep an eye on downstream effects. Again, is this policy causing people to use more services in a way that's not helpful? Are costs going up in other places? Are there other associated outcomes now that have happened because of these policies? Some of that which could be really good, some of it may not be so good. So we want to evaluate all of that. Next slide. And then this was the step that I mentioned, I added on here, which is policy refinement. So how can this policy be improved? Nothing that we ever launch in its initial state is perfect. So we really want to be sure that we go back, we refine it. Sometimes that means broadening what we're doing. Sometimes it means narrowing what we're doing. It could mean increasing or modifying the incentives that we've proposed. Maybe we need to do more. We may need to build new partnerships. There may be people who we didn't include originally in these conversations who we really do need to be including or need to be working with more closely. Maybe we need to be measuring additional things that we didn't think about measuring before. And then again, always including as many voices and inputs as we can throughout this process. Next slide. And if you click one more time, please. Thank you, and one more time. So when I think about how to bring equity into this process, in my mind, I think of it again as that having that input and that feedback at every single step of this policy making process. It's not enough to just hear about it when you're identifying the problem or when you're implementing it or even in the evaluation phase. We need input at every stage, and it's also our own internal input. We want to be sure we're talking to as many people on our teams, getting as many viewpoints as possible, so that it isn't just this siloed view of whoever happens to be at the table. Next slide, please. I'm sorry, actually, yeah, this is great. Thank you. So these are some of the questions that we always want to ask. Who is benefiting? Who is getting hurt? Where's the money? We know that money and power are critical pieces of this whole thing. Are there root causes that we haven't recognized? Are we measuring the right things at the right time? Are there any groups that are being overlooked? And again, are these policies working together or are things conflicting? Please. Thank you so much. I want to be sure to share the floor with my other co-panelists, but that was my overview of one framework for policy making. Here's my email. I'm always happy to talk more about any of this as needed. And I'd love to turn it over to, I believe Dr. Jolly is next.
Can everyone hear me? Wonderful. Thank you for that and sort of really laying out the landscape that really shapes who's prioritized and how funding and access is and resources are distributed unevenly many times to sustain our communities. So today I'll be talking a little bit about the experiences of Black women organized, their sort of culturally resonant, culturally rooted interventions in the state, and how those are reflective of, you know, the ways Black women have been really invested in developing interventions and agendas that that expand access to care, but also that integrates like holistic models of care in ways that are justice centered. And so I want to start with this because the quote that's associated with it is really striking for me. So we can. Awesome. So while the world was in chaos, I was focused on creating life. Jenny LaFleur, who's a Black mother of two from Chicago, and she stated this in an Instagram post in summer 2020, shortly after the birth of her child. And I lead with this image not only because it's powerful, but also because it really brings to focus the sort of sacred and political power of Black motherhood and Black women's advocacy, even in the face of state-sanctioned violence, anti-Black medical racism, and other forms of what I many others, domestic terrorism. And when I see this image, so vivid, so powerful, and I think about it as just sort of one way that Black women have been strategically claiming space to combat limitations, right, in the maternal health, reproductive health broadly policy spaces, the invasive clinical interventions, and the reproductive coercion that a lot of Black and brown women face. And the image is striking of core principles of reproductive justice, which I'm sure some of you have heard. And what reproductive justice is saying not just the sort of the right to sort of not have a child and access, you know, sort of abortion services, but really moving the conversation beyond choice to thinking about the circumstances and the conditions that enable people to exercise those rights, and also foregrounding the right to also parent, to birth and with dignity, and to also live in enabling conditions that sustain our communities. And like many of you, I've witnessed this meaningful work of women of color moving beyond the sort of exclusive focus on a biomedical, often individualistic and authoritative model of care, right, in the maternal health and care realm, and certainly in the policy context or the lack thereof. I've also witnessed and been a part of these recent efforts to produce culturally resonant and justice-centered approaches to birthing and reproductive care in our communities, which are often overexposed and underserved by the U.S. reproductive healthcare system. And yet, in doing this work, I also noticed a glaring erasure. Even as Black women were doing this work, they weren't always prioritized as political and social actors in their own right, as movement builders, as people on the front line of changing the way we consider how care is given and how policy is made, right? And their holistic experiences and voices often weren't foregrounded in these policy agendas, which reduced their not only reduced their visibility in sort of critical decision-making spaces, but it also deprioritized them as populations worthy of the meaningful investments on a basic level, right? And the resources needed to sustain their lives in communities. And so it not only infuriated me, but it really raised several questions, including who is at the table versus who leads these discussions and these policy priorities. And given this mismatch, right, that reinforces the devaluation of Black women's leadership in this area, how might we pull up and create our own tables, our own agendas, and our own policy priorities, right, as we build coalitions? And in the Black women's reproductive justice work that I've seen in Massachusetts, we've certainly been pulling up in all kinds of ways, right, by expanding our coalitions, by building our alliances, by grounding our interventions in the real life experiences of Black and brown women with who've faced like medical racism, obstetric violence, and also by applying our research to evidence-based practices that bridge together dignified care and justice-centered care, right? Because those aren't mutually exclusive. Next slide. And, sorry, but can you go to the previous slide really quickly? Sorry. I also wanted to briefly mention the personal route in which I come into this. And I gave birth to my first child during the pandemic. I witnessed firsthand the sort of understaffing during the pandemic, the utter lack of clarity around hospital policies, right? Continuous visitors being, if they're our birth support not being able to sort of stay if they leave the premises for food or to get tested, which was required. At the same time, that miscommunication about what actually is the policy, right? The lack of testing for birth support, right? And birth back in 3 pandemics not only exposed and heightened these pre-existing inequalities in access to care, quality, and reproductive health outcomes, but it really sort of exposed many opportunities also for intervention. So I don't want to spend all the time focusing on sort of the violence of this care, but also what people are doing in their in meaningful ways to really connect these overlapping forms of violence and to develop interventions around them. Next slide. Cumulative deprioritization is important for our conversation here because what it means is literally the calculations of what is worthy of attention, resources, what is worthy of being prioritized, and decisions about funding investments, about not only budgets, but also kind of sort of who sets the agenda broadly, what kind of programs are done, how they're sustained, if there are accountability mechanisms that allow them to be followed through and followed up and like meaningfully engaged and implemented, right? And so I want to reference the work of Dr. Tamara Lewis, who described the cumulative deprioritization as a notorious established hierarchy of care where Black women, there are many small decisions are made by medical providers that lead Black women to receiving inferior care, right? And we know there's a range of these kinds of decisions about, you know, who's prioritized, who's viewed as an emergency, whose pain is viewed as worthy of being responded to, who's a meaningful side of intervention, who's a meaningful side of, you know, diversity initiatives, right? And these claims around implicit bias, which ain't real. It's really explicit bias and racism with concrete impacts on who lives and who dies, right? So these actions and practices are not always overt and tangible, but they do build up over time to determine who's valuable and by extension, who's deserving of this life-saving care. And I think about cumulative deprioritization as we discuss policy because it not only sets the agenda, but also it enables a kind of normalization of the harm that is done. And we know this harm that's done from anywhere from the dismissal of self-advocacy to invasive procedures to the sort of, you know, down the list in terms of the pathologization of sort of natural maternal health process in ways that violate autonomy and bodily integrity of birthing people. But deprioritization, I want to bring home the point, really shapes policy because these calculations, as we mentioned, are not only translated into policy agendas, but they also really shape, these in turn shape the kind of opportunities that exist to challenge the pathologizing narratives of Black maternal health, but also enables us to hold these systems accountable for systemic change, right? Next slide. I just wanted to briefly mention the local landscape really quickly. And I wanted to share this map and also to trouble a map because essentially the map is communicating that there is sort of it's viewing Massachusetts as not a maternity care desert, right? In terms of sort of access to medical care providers, access to sort of meaningful community-based care, access to sort of the health services that support birthing, reproductive health, and life broadly. And I want to point this out because what's really important to think about as we're thinking about this is that the ways in which location, class, and privilege unfold is that it shapes access to services in uneven ways, even if it doesn't appear that way initially. Next slide. And this is one of the examples in which it does that, which this map kind of shows the way in which disadvantages is distributed more intentionally. And why this connects to the point that we're trying to make is about access in terms of policy is that part of the sort of claim that Massachusetts doesn't have a is not a birth space of birthing desert is because there's a high concentration of sort of medical care, right? We know Boston, Cambridge in that area, but when you really move to those different spaces beyond that sort of high concentration, we see the sort of critical gaps and the lack of access, whether that be in terms of transportation, geography, the built environment, or just literally the absence of medical providers and especially community-based care practices and models. Next slide. And the labor of Black women is here to save the day. But I also don't want to just focus on saving the day in a sort of savior complex that advocates the responsibility of the state and policymakers to respond to us and to sustain our communities in a meaningful way. And I just wanted to point out that one of the important work that's happening is with the Massachusetts Maternal Equity Coalition, which is a Black woman-led reproductive justice coalition. Big up to my co-organizer, policymaker Yamina Romulus with HICFA. And what it's focused on is addressing the structural racism and systemic inequities in maternal health care in Massachusetts by elevating the holistic lived experiences of Black and brown birthers. Why is this important? We know that the biomedicalized model really erased the experiences of violence and also the opportunities to provide dignified care. We also know that a lot of the times, the sort of compartmentalization of these individual roles that really have important impacts on the quality of care and the provision of services distributed is often really separated, right? So what I love about this coalition is that it's really thinking about how to bring together maternal health professionals, advocates, community leaders, policymakers, state legislators, and birth workers, academicians, researchers, to really recharge and advance this work in a way that's really connected to and thinking about the policy the policy processes, right? So this brings us back to the question of who voices are at the table and with whom are they in community with. That's an important element of our work, right? Because we can't claim to be doing meaningful work if we're not foregrounding it in the people that we are claiming to serve. So really being mindful of that mismatch as we're also rooting our work in meaningful partnerships and coalition building, and not treating Black and brown people and birthing and parenting people as simply afterthoughts to research, advocacy, and policy, but integral to the process, as my co-panelists just shared. Next, and I just wanted to point out that these were some of the examples: evidence-based model, community-based care, collaborative care, mobilizing communities while really centering those holistic experiences, culturally resonant. I'm happy to talk about these in the chat, but I want to leave room for my the Honorable Rep Liz Miranda to sort of share her experiences and work. Next slide as we wrap it up. I absolutely want to, as we think about culturally sensitive resonant interventions, I absolutely want to prioritize sort of spotlighting what this can look like. And it's really the sort of cross-sectoral and intentional, intergenerational and intersectional ways that we're really building community to build bridges across the silos of maternal health, but also to really think intentionally about what that means for the work moving forward, even as we emerge out of COVID-19 or enter into a different reality. Next slide. So as I've mentioned, we all occupy different varying roles and positions in the sphere. And what's important is that we bring this reproductive justice lens to really thinking about, well, how do we make sure that these the sort of policies that we're thinking about, that we're advocating for, that we're sort of in community around seeing that they get passed through, how do we ensure that they're aligned with those sort of integral experiences of the people that we're engaging with, and from our multiple different roles in positions in this work. And I just wanted to point out that there are three, the Out of Care Hospital Birth Access and Safety Act, which is really thinking about integrated maternity care system. And as we opened up with my presentation, that's one of Massachusetts' rank in the bottom sort of sector for that integrated care. Also more freestanding birth centers, and really thinking intentionally about infrastructure and better financing for developing this work, and especially in the communities that are underserved and overexposed, where there also has to be also have had recent sort of shutdowns in the last few years of these centers. And finally, the sort of Medicaid coverage of doula services to provide this expansive care, particularly for people, the populations that we know, marginalized groups that have access to Medicaid service, but limited access to the realm of care. And I want to pass the mic to expand on this important work to my co-panelists. Thank you.
Hi, everyone. How are y'all doing? Shouts out to my co-panelists. And there are 285 of you guys in this room. I am feeling your love and energy. And I'm just feeling incredibly honored. Keep dropping those yellow hearts and continuing the conversation. Shouts out to the Mother Lab. This has been a phenomenal morning and afternoon, and just happy to be here. My name is Representative Liz Miranda. I have been an elected official in Massachusetts for 3 years, 3 months, and 7 days. And yes, I'm counting. So I'm happy to be here because I've been a Black woman from Roxbury my entire life, which I'm very proud of. And when you're talking about sort of the communal, I can't even say the word, the deprived, I can't even say the word today, I'm so excited. But the point I'm making is when you talk about not being prioritized, particularly in the space of Black women in government, here in Massachusetts, there are only 5 Black women in the entire legislature. There are 200 seats in the House and Senate, 160 in the House, 40 in the Senate. And I think we make up, us 5, a history of 15 or less women since 1600. So we are a special, unique group and all committed to the upliftment of our communities. So next slide. So I want to tell you a little bit about my story, talk about the legislation that I've been able to help push in the House and Senate here in Massachusetts. But my story really starts that I got elected in 2018 on a historic night. Rep. Lugardo, then DA Rollins, and Congresswoman Presley were all elected in Massachusetts. We made Massachusetts history by being 4 Black women elected on the same night across county and state lines. And that was an amazing time. I get inaugurated in January. I walk into a presentation. Speaker Pro Tem Pat Haddad, who's been in the House for a very long time, invited all women legislators to a presentation by March of Dimes. In that presentation, I essentially hear, and I know Aaron Jones is probably here too, that the top 10 poorest zip codes with maternal morbidity, well, that had the highest rates of poor outcomes, particularly for Black and brown women and their babies. 6 of them were in my city and 5 of them were in my district. So looking at a map and you see the numbers and it says Roxbury, Dorchester, Mattapan, Hyde Park. It says Bristol County and also Worcester and Springfield. And I think to myself, you know, here's some more bad news. But also I had this deep sense as a Black woman who's not a mother yet, that I didn't want to die, right? And I was listening to more bad news about how nationally 3 to 4 times the rate of white women, Black women were dying. But even here in Massachusetts, we are dying 2 times the rate. And I thought about the sort of faux liberalism that I soon learned about in the state of Massachusetts. We don't think anything goes wrong here. We think we're incredibly wealthy, which we are. 1 in 20 people are millionaires here in Massachusetts, but we are not immune to the critical racial and class differences that are across this entire country. So I walked out of that room, and many of my colleagues did not see this, but I was inconsolable in the elevator going to my office. And 3 of the reasons why is because I had almost forgotten that in 2017, I watched my sister give birth to her daughter, Mila, at 21 weeks, and the baby didn't survive. And I kept remembering in that elevator ride how my sister complained of pain the night before and was told that she was anxious, to take some Tylenol and rest. And my sister kept complaining of pain, went into early labor, and a few hours after my sister was told to rest, we were rushed to Boston Medical Center, where she gave birth to her daughter, who didn't survive. Then I thought about my cousin Maria, who had the means to, but was alone giving birth, and hired a doula and spent a lot of money in doulas and night nurses, just to be able to give birth to her daughter, Olivia, and be able to be a parent, a first-time parent. And I thought about my friend Jamina, who gave birth to her daughter, Rennie, and after giving birth to her daughter, Rennie complained of stomach pain, and they sent her home. And soon after 2 weeks was sent to the hospital in septic shock, because they had cut pieces of her intestine in her stomach. And essentially, she was dying from 2 weeks because they did not believe that she was in pain. Again, being told that she is just nervous and anxious, and the pain was normal. And so I come to you today, not only as a legislator in the state of Massachusetts, but as a Black woman who doesn't want to die giving birth, but also doesn't want Black women to suffer, or Indigenous women or BIPOC women to suffer in the state of Massachusetts, because we are not listening to the experts, which are us. Next slide. So I have spent the better part of my 3 years really focusing, and we already know the news that we've heard, but I just want to give highlight two facts: that Massachusetts is the most expensive state in the United States to give birth, which is a shame. I think it was $38,000. And that maternal mortality is actually on the rise. How do we have this happening when we're arguably the most educated and wealthiest country and state? And that we've made a lot of interventions. When you heard from other providers, including Dr. Viveka, I hope I'm saying it right, Viveka, Dr. Viveka, that, income, education, studies have shown in the past 50 years, regardless if you have a good education or are making a lot of money or live in a prime real estate zip code, that still doesn't change. Next slide. And so there's some slides about with the CDC releasing its increase 18% between 2019 and 2020. Obviously, we talked about, Dr. Jolly, about the triple pandemics. We went through a racial reckoning this country has not seen since the 50s and 60s. But we also were going through a public health pandemic, a housing pandemic, and an economic pandemic at the same time. And I think all of us can agree that we've all been touched by this COVID-19 crisis, and we all are not 100% well. I don't know about y'all, but these last 2 years have been a lot on my mental, emotional, physical, and community health. Next slide. And so I don't know how we got this done, but one of the things we were able to do in my first year, thanks to Rep. Khan, Senator Roush, and the coalition of people working with Reproductive Justice Now, were able to pass unanimously a Maternal Inequities Commission. Now, it was not all flowers and sunshine. We have spent the better part of the year having 4 listening sessions, but I want to highlight 3 unique things that came out of this commission. It is the only commission that had 95 to 98% Black leadership in this commission. So out of the 28 commissioners, at least 24 were of color, Latino and Black. And we should celebrate that because it doesn't exist. There are over 750 boards and commissions in the Commonwealth of Massachusetts. And we're lucky if we have 1 or 2 Black voices on any of those boards and commissions. And so to have something like this was phenomenal. 2, you would think that in 2018, 2019, 2020, that talking about maternal health or birthing justice or birthing people would not be new. We've been giving birth since centuries, since the indigenous people were leading our country and our Commonwealth. And to think that for most of my colleagues, they did not know that this was a crisis across the country, did not know that this was a crisis in the Commonwealth. But the interesting fact, it is bicameral, okay, bi-party. people do not care. We want to save birthing people and their children. And so when this passed unanimously, particularly as me as a freshman legislator, it was something that we should have been incredibly proud of. And I still am today. And right now we're currently working on a report that's going to be released this month that hopefully everyone will take a look at, to say some recommendations that we hope the Commonwealth will agree on as things to move the needle here in the state. Next slide. So I'm going to go through the next slides pretty quickly. The commissioners are listed here. You'll remember some of these names. See, some of these folks are thought leaders, but it wasn't everyone. It wasn't an exhaustive list. But I just want to say to anybody that's from another state, starting a commission was a great way to address these issues, but you should take into context some of the things and lessons learned, which I'll share later, about you can't just form a commission. You have to really think about who's leading this commission, thinking about who is present in the room, and take into consideration that this, like many other systems of delivery and care and knowledge and research, have structural racism embedded in the processes. And so to take a second look at the processes would be incredibly important. We decided on 4 listening sessions. Was that enough? We decided that the chairs of the Public Health Committee, who are already incredibly busy in the Commonwealth, would lead this commission, but they happen to be 2 white women. And they did a lot of great work, but the 2 things is like, you can still be positive and still cause racial harm. And to think about what that would mean going forward further in other Commonwealths or other states across the country. Next slide. So I'm going to specifically talk about 3 bills that I championed, that I have pushed through. One is to extend postpartum coverage. I saw Yamina here in the room. Thank you to Healthcare for All. It was reported favorably out of committee, but thinking about that we need coverage over 60 days, a full year of coverage isn't even not enough, but we want to start there to think about how we can make that happen here in the Commonwealth of Massachusetts. So H1297 is that bill. The next slide, please. The next bill is, I saw Becky here. We went to high school together. Shouts out to Becky and the Boston Public Health Commission. But H2371 is a bill that I filed with Rep. Fluker Oakley, who is another Black woman with 2 out of 5, who represents parts of Hyde Park, Mattapan, and Milton, to make sure and allow departments of public health to conduct fetal and infant mortality reviews. We do not know as a state how many babies we're actually losing and where. And that is incredibly sad, because when I think about my sister's daughter, Mila, she mattered. She had a story. She had people who loved her. And it's incredibly important that when you talk about birthing with dignity, to ensure that our children are not forgotten, is an important piece. Next slide. And the last, which actually was my first bill that I filed, and thank you to March of Dimes, which is an act relative to Medicaid coverage for doula services. I remember reading the Ancient Song report, getting that presentation from March of Dimes, and learning about the experience of my cousin and friend Maria, one of my best friends, Maria, who said to me, I didn't even know that a doula was a thing. But when I went to my doctor and I said, hey, I'm alone doing this thing, she was like, have you ever considered a doula? But at the time, making sure that she hired a doula meant that she had to come out of pocket to pay and equitably resource these women and men who are providing this service. And that bill has also been reported favorably out of committee, and currently it is in Ways and Means. So next slide. So one of the things I didn't share, but maybe I did because I'm a little nervous. So I want to talk about that there are plenty of bills in the Commonwealth of Massachusetts. Every year, 7,000 bills are filed through those 200 legislators. Very few get to the finish line. So hundreds get reported favorably, some get extended, and some get sent to study, which sadly means to die. And we hope that many of our bills do not get sent to study. And those 3 bills have all been reported favorably, and we're super excited about that. But we have a birth justice task force, within the Women's Caucus. So finally, in 2022, we have reached the number of 62 women in the entire legislature, which means that there have been 221 women since the beginning and formation of this Commonwealth out of 20,000 men who've been elected to office. So we now are finally 30%, one of three in the Massachusetts legislature. So I hope that some of you that are listening will run for office in your state, and others will run for office in Massachusetts, because we need you to further these policies. We need more women and more birthing people here to make sure that we are ensuring that these bills get passed and lobbied correctly. Next slide. And so where are we going? And so there's some 4 immediate steps, and I will share with you all. When I first got elected, I didn't even know how to write a bill. And I'm sitting in front of you all, really inspired and motivated, and was really deeply supported by multiple organizations that I can say to you that in my 3 years, 3 months and 7 days, I've been able to pass 5 bills. And that is only, I think, a little bit by the grace of God, but also because I told myself that I was worthy enough and belonged, that even though I didn't know how to write a bill, I would learn how to, that I would work with very smart people to ensure that we not only write really great legislation, but ensure that across the aisle, people care about this issue. And so the next 4 steps that are really happening in the Massachusetts legislature, which people should pay attention to, is that this report will be released. I'm working on, and if any of you guys are in Massachusetts and want to be part of the group that is hoping to develop a birthing justice omnibus bill, the federal government, when you talk about Congresswoman Presley sharing that the Black Maternal Health Caucus was able to pass an omnibus bill, which had 12 to 14 bills within it across the line, and ensure that there were budget priorities through the Build Back Better Act. That is a feat in itself, and we want to make sure that that's done in Massachusetts. We want to put our money where our mouth is. We're a very wealthy state. We have $48 billion in our state budget. Are we funding birth centers? Are we funding community-based organizations? Are we funding research to ensure that as we make these recommendations that things happen? And the last thing is a task force or working group. This commission ends this month. But can we do a do-over? Can we have a task force to complement the work of this COVID-19 coalition? Can we complement the MMRC, the Maternal Morbidity and Mortality Committee in the Commonwealth, to have people with lived experience across the Commonwealth make sure that we're implementing and we're actually doing what the report says? And are we implementing and ensuring that these other bills pass? And to end, I just want to say that I have enjoyed being in community. I want to thank Dr. Ndidi. She was part of that coalition. Tamoria Seba, Commissioner Hall, and many of the commissioners that I've seen in the conference today just say thank you that you entrusted me to help get this commission across the finish line. And for the organizations, including Healthcare for All, the Public Health Commission, and the March of Dimes, I've had a great 3 years, and I look forward to taking all this work to the Senate.
Thank you so much for this incredible session. We are so honored. I'm taking a quick look. I don't think we're going to have time for question and answers, but we do have a networking session at the end of the day. And thank you again to our amazing panelists. I am so proud to be here in the Commonwealth. I remember when I first got the job, I was like, Massachusetts? Now I'm like, Massachusetts. It took me a while. The Jersey girl is fully on board. Thank you all so much for your energy, for your commitment, and the work that you're doing. I'm honored to be friends and colleagues with all of you. Our next session now is with the incredible, amazing Dr. Zaya Malawa. You can get that from the lobby and the main stage. Thank you all so much, and see you over there. Thanks.